Bad thing to have a halo? I'm taking the mask off, okay. All right, so TR bands, basically what it is, it's a band that gets put on the wrist, and there's a thing called, it says Terumo here. So Terumo is going to be on the inside, and when we put this thing on, I got it. So it says Terumo, and it goes on the inside. There's a little green dot. The green dot is supposed to be where the insertion site is. So just like your IVs, when you stick an IV, you go in at an angle. So the actual where it hits the vein, or with this case hits the artery, it's going to be a couple millimeters up from where they stick, right? So that green dot is supposed to be over. I don't know if you guys can see it. Okay. So the green dot is supposed to be over, and usually it's on the right side, but the stick will be above it. I like to give a pen. Yeah. All right, so we did that. So here's the stick. We're just going to pretend. Okay. So always the Terumo or the label on the inside, so it's on that one, it's going to be on the inside here. But that's like where the stick is. And that green dot's going to be just above it. Okay. That's going to be where the most pressure is. So stick, green dot. So it'll be up just a little bit. Because like I said, the angle coming in with the needle is going to be up a little bit. Okay. So stick and then green dot. Which should be in line there with the so you'll see.
Show my camera.
Yeah, so stick, green dot, just above it. So then they'll have air in it. And how we put these things on, we actually start with 20 cc's in. Yeah. So we start with 20. We'll push that in. And it gets really tight on the patient. Yeah. And then what we start doing is we start pulling back. 1 cc until we see a little flash of blood. Once we see that, we'll put in 1 or 2 more cc's of air back into it. Typically, it's going to be around 10 to 12. So it starts with 10 to 12 cc's of air in here. Protocol, keep it on for an hour because you guys are getting just the diagnostic. You guys won't get the interventions. Keep it on for an hour and then start pulling back 1 to 2 cc's in air. If you see blood coming back, put it back in and wait another 15 minutes. So then you'll just keep letting that air out every 15 minutes, 2 cc's, and then until it's done and out. And then you pull it off and then you're good. You're going to have these braces on. Initially when they come up, they're on this big bad boy here. So the arm will be like this. It's kind of hyperextends that wrist for us. This whole camera business, guys, jeez. So they'll be on this here. It'll be so you can, they're not comfortable, but it works. So, and then after this comes off, you can take this thing off too and just leave this brace on for them. That way when they go home, they have a brace here. Just makes it so they don't use this wrist. So this one we send up with us. We're gonna get you guys some of these, and then we can just order them. I don't know what we have somebody who does all the ordering for us, so we'll make sure you guys get them. And a lot of times, if they've been in crew for a little bit, we may just have them on here if we're gonna just let them recover for the rest of the 2-3 hours, whatever, up on you guys' floor. So they need to wear it for at least 24 hours. And then for, I want to say like 3 to 4 days, they're not going to lift anything over a gallon of milk. So under 10 pounds is what it's kind of the limit there. So good question. But we have on the discharge, you guys have your discharge summary thing. There's a place on there that says radial, what does it say? Can't remember because I don't do that part usually. But it's a radial one, and you can print it out, and it will have all the instructions on there as well. So that will make it a little bit easier so you guys don't have to memorize everything, but it's just on that form. Okay. Any questions on TR bands? If for some reason I got a call last week, this tip broke off, and then all of a sudden the air just all comes seeping out. Don't freak out, first of all. No, what do we do? So it did this last week. Hold pressure. I mean, that's a simple thing. They ended up going to get a new one so they could get a new syringe on it, and then ended up just putting air back in it, and it was fine. But, I mean, if it's bleeding, hold pressure. And it is arterial, so you want to just hold above it, just like you normally would. And just hold 10-minute hold, and it's going to be good because they're not going to be heparinized or anything that way either. If for some reason it is still bleeding out that way. Okay. Any questions on TR bands? Every 15 minutes, about 2 cc's of air. Unless, like I said, unless you see it start bleeding, then just put that 2 cc's back in and wait another 15 minutes, and then just slowly just keep backing it off. Yeah, under your lines, drains, I think. Or free text it, yeah. Yeah, you guys would know better on that than I do. So. Purple. So they will check cap refill because we do put them on really tight initially. They usually always turn purple. So just check cap refill, make sure that they're still getting. And if you do that, correct. Pulse ox on that side. So if you see cap refill that is not getting flow or not returning back, then let out in 1 cc air, 1 or 2, and just to see. Most of the time, it's going to be purple, but you'll still get good cap refill. So you'll see that. What was the second part that you were saying on there now? Yeah, so it will be normal. It'll be normal to look purple. Like, oh, and then the pulse ox, yeah. So pulse ox, all we're doing is just make sure we're getting the blood flow through there and their oxygen's still getting to that hand. So that's why they'll have the pulse ox on the radial side where the side is. Yeah. And then you know too, if the hand's purple, but you're still having good stats, that you're good. Okay. Yeah, correct. Yeah. Yeah. Any other questions on these? Okay. Yeah. Release some air for it to get back. Yeah, because most of the time, I mean, when we check for the radial, and we used to, we don't do it much anymore, but you'd always check to see, it's called what test? No, I can't even think of it. Allen's test, yes. So that way we know that we're still getting circulation through the ulnar side. The blood is still going through there. We are supposed to, yes. Yeah. How many was it? Was it 12? Was it 13? Yeah. So typically they'll write how much air is in it, what time they put it on, and then initial who did it. So, okay. Yeah. And I'll remind them, make sure that our staff is doing that. Because I know yesterday we did 3 cases and with the TR, and the guy that was scrubbing, he put it on everyone. So, but yeah, I'll remind everyone to do that. So, okay, so when it's after the TR band's off, you'll put them on this wrist board, put a tegaderm over the side, and you're just basically going to watch it again and just make sure it doesn't bleed. That's all we're doing. And by then, you should not have a problem bleeding at all. So, but just like you would on any puncture site, just make sure it's not bleeding. But yeah, and then with the wrist guard on it, all you're telling them is that you're just keeping that stable, so you're not going to bend that wrist. Once you start doing this, then you have a chance for it to open back up. Yeah. Just hold pressure. I would say, yeah. By that point, you probably already threw away the TR band. Maybe just hold pressure. You can keep as many as you want. Oh, the patient's there? All right. If you lose this, we do have a couple extra. hanging out in our crew area, so our pre and post area, or we just open up a new one and get it. But yeah, yeah. So last time the house, never. So when that one did break off, I just told the house supervisor where they were, and he ran up and grabbed one and then went. I think it was. I don't remember if it was PCU or 3 West. I don't know, but I just said, "Here it is. Go get it." And they were holding pressure, and then they ended up just putting that TR band back on and re-inserting some air. So, like I said, 20 cc's is how we start putting it on, and then we slowly start taking out some air in them. And like 10 to 12 is where typically we leave them at. Question? Okay, so yeah, we'll put in, so initially when we start, we'll go 20 cc's and we inflate it all the way up, okay? And then what we start doing is just start backing off. So we say 2 cc's, 3 cc's. Once we see a little flash of blood coming back, we'll put in another 2 cc's usually. Yeah, because we don't want it to bleed back. We're trying to stop that bleeding. And then plus we still want flow to get down through the fingers. Correct. That's a good point. It'll just all of them pop. Yeah, so as once you hook it on, just keep your thumb there, and then you'll slowly just back it off.
And if you're waiting the 15 minutes, pull it off. That way you're not sitting there holding.
Oh yeah. No, don't just leave this on. So every 15 minutes. No, that's a good point.
You're not standing in the room for the 4 hours or 2 hours to get that thing out.
Correct.
Take 2 out, pull it off.
Yes. Take your 2 out, pull the syringe off, because that way it will keep the air in. If you leave this on there, that air just backs out and it's done. Yeah. Yeah. Correct. So yeah, once you take this off, valve's in there, one-way valve, it just shuts it off. So yeah, right in there. Absolutely. This is your guys as you guys play with it, practice it. You can get a feel for when you do. See, once you do this, that air is coming right back up. So this. Correct. So they'll put it right on top here. They'll say 12 cc's of air. That was in there. And so when you go to start taking it out, you'll take out 2 at a time. 12, 10, every 15 minutes will be like an hour and a half. Correct. That way you know the starting point. Yeah. Very good. Any other questions on TR bands? On post-cath, I mean, you're going to basically do this. You're still watching for bleeding, watching for infection, anything that way, because it's a puncture site. So you still check for that stuff. And if the patient complains, like if they have issues or if you see a hematoma forming, just the blood will start filling up, call the doctor, call the cath lab. We can come up and take a look at it. We have had it where we put one TR band on, and if we put it a little bit low, we can actually add another one on top of it. We always will squish out that hematoma first and just tell them they're going to have a big bruise on there. So that's just going to be expected. Post-procedure. Correct. Correct. Yep. Yeah, so we've already gone up. We looked at the heart. Arteries look good. They're open. There's no blockages, no stents, no nothing. Just normal heart cath. And then done, and all you have left is this. This is the only thing that you have left. Yeah. Good point. Correct. Yep. PCU, ICU, that's where all the stents and interventions will go to. Yeah. For now. No, I'm just saying it. Hopefully you guys will never have to see him. It might one day. They'd say, "Yeah, you guys will be good," but I doubt it. They'll keep him PCU and or ICU depending on what we end up doing. good, comfortable. Like I said, always call us too if you have any questions, concerns. Have no problems coming up and taking a look at it and being like, oh yeah, a little hematoma is forming. Maybe we'll just put pressure on it, relieve it, put another cc of air back in. So that's not a problem. Yep. And then, like I said, talk to your doctors if there's any issues. All of our doctors here are amazing. We have actually really good cardiologists. I worked at everywhere from pretty much the whole Western hemisphere here with hospitals and doctors as a rep before. So we have some really good doctors. So correct. If you see blood, put a little bit more in, and typically after an hour of pressure on there. Yep. If you don't see it, then just every 15 minutes, take out 2 cc's more of air. And if you don't see any, take it off. You're done. Put a bandage on it. Just make sure they're not moving that wrist all around, and then you'll be good. Or they want to scrapbook it wherever she went. So yeah. So when you guys, this will already be on the wrist by the time it comes up to you guys, and this will either be put in here. So it's there, or we'll just tape it to the bedside, the rail, so you guys have this as well. So yeah, it'll be in this one for you guys, and then you can switch them over to this one. Once you take off the TR band, yep. And then this is more just to remind the patient not to bend that wrist when they get home and things that way. So, okay. Transition now to pacemakers. So you guys always have taken care of the broken hearts, the sick hearts, and then we fix them, and then they go somewhere else. It's like once they're fixed, it's probably easier to take care of than when they were heart rates and heart block in 30s, and you guys are taking care of them. So biggest things that you're going to watch for with a pacemaker. So now we're switching over. Hopefully not. It shouldn't. So yeah, so we always typically go in the left side, unless they're left-handed, then we go on the right side. But so most of our patients get a left side thing here. And basically what we do is we put a little pressure dressing on with a tegaderm on the outside of it. And the biggest key for you guys to watch for is that if it starts getting bigger. So what happens is we make a little pocket, we cut it, we basically just pull the skin away to be able to put a pacemaker in there. A little small battery that's probably about that big. We cauterize stuff in there. Sometimes if we have a little arterial bleed that you didn't cauterize, that can happen. But typically the doctors are pretty good about making sure there's no little bleeders in there. And then so that we get sewn back up, little dressing over it, and then the tegaderm over that. So you're just watching that site. You're just checking to make sure it doesn't get bigger. If it starts getting bigger, same thing as before, bleeding, hold pressure on it, okay? Call the doctor, let them know. Most of the time, you're just going to hold pressure and then redress that site there. Biggest key for pacemakers and dislodgement of the leads. So we put a lead coming down, one up in the RV, one up in the RA. So we don't want those to come out. So if the patient starts going like this, moving their arm up and down, that's when those leads can go boop, pop out. Because all it is basically is like a little spring that we unwind, and it just attaches to the tissue, and that's where it stays. So if for some reason they're moving their arms around, then they're going to possibly come out, and that's when we have to go back in and just reposition that lead. So typically, they can do absolutely. So typically a week. They don't want them to be doing a bunch of moving. In our old hospital, we used to just have them in slings all the time. I think we're going to start doing that here. Liz, is that correct? We're going to try to get slings. That way you have a sling, they put their arm in it, and they know not to move it, raise it up and down, things like that. So How long does it take to do a pacemaker? Depends on the doctor, but most of our doctors, 45 minutes, it's in, done. They local anesthesia. So we just numb up this area here. They'll make an incision. We do a venogram so we know where that subclavian vein goes through. They do 2 sticks, and then they put little wires in to hold the place open, and then they put the leads over that wire and go in, and then they unscrew it, and then if they test it, we have pacemaker reps that will test it. If the threshold looks good, everything looks good, then they do the next lead, and then they'll put the battery up to it, put it in the pocket, and then we sew it up. Sew up the sub-Q tissue and then the skin at the end. So usually 6, 7 years. They'll last a while. Yeah. Yeah. So they'll have an end of life warning once they go in and see the doctors. And they're like, okay, within the next, I think it's 6 months, we need to change that battery out. Yeah. So the battery gets connected to the lead. The battery runs the whole thing. Yep. And then it's just sending impulses down to the heart to beat, basically. So yeah, then what we do there, we just make a new incision, take that, we call it a can, take out the battery, unscrew it, and then pop the leads out, and then pop the leads into the new one, screw it back in. If they're dependent on the pacemaker, we put in a temporary pacer while we do that. We have some docs that'll just quickly do it, be little cowboys, versus getting a temporary pacer. But most people here will do a temporary pacer. So absolutely.